Welcome to Episode 6 of IMPACT Medicom's podcast series on precision medicine in oncology. In this episode, hosted by IMPACT Medicom's Sarah Doucette, we welcome Dr. Raul Gonzalez, Associate Professor of Pathology at Harvard Medical School and the Director of Gastrointestinal Pathology at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Dr. Gonzalez is a surgical pathologist specializing in gastrointestinal pathology. He is the Editor-in-Chief of Pathology Outlines and the Reviews Editor for Histopathology. He also serves as the Vice Chair for the College of American Pathologists Surgical Pathology Committee and the Website Committee Chair for the Hans Popper Hepatopathology Society. In this episode, Dr. Gonzalez discusses testing methodology, particularly for mismatch repair deficiency, as well as potential emerging biomarkers for metastatic colorectal cancer. Hope you enjoy it.
Hello, listeners. In this episode, we are picking up where we left off in our last episode with Dr. Charlene Gill, where we discussed the biomarker testing standards for metastatic colorectal cancer in Canada. So that included testing for extended RAS, BRAF, and mismatch repair deficiency or microsatellite instability. Today, we have surgical pathologist Dr. Raul Gonzalez with us to talk in more detail about testing methodology. So I was hoping, Dr. Gonzalez, that you could start us off by telling us a little bit about how biomarker testing for metastatic colorectal cancer is done at your institution.
Absolutely. I'd be happy to. First of all, thank you for having me on the podcast. So we try to do most of our testing at the first available sample, which is usually going to be a biopsy. And we actually recently updated our standard operating procedure for reflex ancillary testing. So I have a current version of the document in front of me that I can share. For any gastrointestinal tract cancer, including upper GI, small bowel, and of course colon, which is the focus of the talk today, we do DNA mismatch repair protein immunohistochemistry. So we stain for all four typical proteins, MLH1, MSH6, MSH2, and PMS2. And again, we prefer to do that on biopsy. We don't always have biopsy material available if the patient is biopsied on the outside and then comes to us for a resection. If we do only have a resection, we will, of course, do that. There are some caveats to that, which we may get into later in the discussion, but the biopsy is preferred. We are also doing HER2 testing routinely for upper GI. We can do it for lower GI, but that's at a request. And I think we'll talk a bit more about HER2 later. We also do mismatch repair testing for any metastatic focus of gastrointestinal tract cancer. If we get, a year or two later, the patient develops a metastasis to the peritoneum or to the lung, something of that sort, we will generally do the protein immunostains again, just to double check the MLR status of the metastasis.
And as a great deal of your work obviously involves testing for mismatch repair deficiency or MMR, we're going to focus a lot on this biomarker. So first off, I know you mentioned the point in the patient pathway where you'd usually do that testing is upfront. So what important information does that provide?
Certainly. So mismatch repair deficiency is one of the main pathways of carcinogenesis in the colon. It happens in just about every organ system, but the colon is sort of the most well-studied area for this and where a lot of the advances in this testing took place. As I said, we prefer to do it on biopsy, and there are several pieces of information that can be provided. In brief, I'll say that while there are a couple nitpicks, we basically report the protein staining results as intact or deficient. Depending on whether the stains are intact or deficient, tells us several things about the cancer and possibly some things about the patient. If the staining is retained, then the cancer probably arose through the sort of chromosomal instability pathway, the typical carcinogenesis pathway that's been taught in medical school for decades. This patient will have sort of the average response to adjuvant therapy, neoadjuvant therapy if rectal, and will also have sort of an average prognosis depending on stage. If the cancer is mismatch repair deficient, however, the patient's overall prognosis is actually better. These colon cancers overall have a better prognosis than stage-matched, mismatch repair proficient colon cancers. The chemotherapy that the oncologist will select is also going to be different. I'm not an oncologist, so I can't really get into the weeds on that. But my main understanding is that 5-FU is not beneficial for mismatch repair deficient colon cancers, but immunotherapy, specifically PD-L1 immunotherapy, is beneficial for these cancers. And that, of course, has been really picked up in the past couple of years. Another important point is that if a cancer is mismatch repair deficient, it may have arisen due to a genetic syndrome. The main one is going to be Lynch syndrome. Now, when I get a colon cancer and I stain it and it turns out to be mismatch repair deficient, 80% of those are actually not going to be syndromic. It's going to be sporadic. It's a patient without a heritable syndrome, without a germline mutation, but for whatever two-hit mechanism in the gene in question, their cancer developed along this pathway. So they still have the better prognosis. They still have the different response to chemo, but there's nothing germline going on. It's not going to be particularly a concern for their family. However, 20% of those mismatch repair deficient colon cancers are going to result from a germline mutation in one of the genes corresponding to the proteins I just mentioned, MLH1, MSH2, MSH6, PMS2. In that case, this patient's family members should potentially be tested, as they may carry, the same germline mutation and may also have Lynch syndrome, which would put them at increased risk for developing colon cancer, endometrial cancer, a large variety of cancers.
So what are the differences between sporadic versus hereditary mismatch repair deficiency?
So if the deficient protein staining pattern is loss of MLH1 and PMS2, then there's a pretty good chance that it is sporadic. It is not hereditary. Now, it could be, and we need to do additional testing. I think most labs do molecular testing for the BRAF V600E mutation. You can also do MLH1 promoter hypermethylation testing, which will tell you the same thing. But most of those are going to be sporadic. However, if the pattern of loss is anything else, if it's MSH6, MSH2 loss, isolated PMS2 loss, et cetera, almost certainly Lynch syndrome, almost certainly hereditary. There's a small number of cases that are still sporadic because nothing is ever 100% in medicine. But those patients should definitely be referred for a genetics consultation for workup, because there's a very high risk that we're dealing with a syndrome in those patients.
And so mismatch repair deficiency testing, it's been used in practice for many years. Are there still some pitfalls in this type of testing that pathologists may not be aware of? And how would you go about addressing these?
There are absolutely pitfalls. I think most pathologists are generally aware of the pitfalls that exist, and there have been several good review articles. You pull up your favorite article and you read, here's 6 or 7 staining patterns that could be a pitfall that you don't want to make a mistake when interpreting. The good news and bad news for these pitfall patterns is that they're very rare. I haven't even seen all of them, and the ones that I have seen, I've only seen a couple cases. So it's good that I'm not encountering this frequently, but it's so rare that when you encounter it, the alarm bells go off. Oh, am I missing something? Am I misinterpreting this? How do I deal with it? So I can run through a couple of them. One possibility is that there does appear to be retained normal staining in the colon cancer, but the staining is not as strong as it is in the internal control. The non-cancer tissue in a patient's biopsy, the lymphocytes, the normal background colon mucosa, if it's present, those sorts of tissues should have normal staining for the protein. So if there is what looks to be some staining, but it's kind of weak, it's not as strong as the internal control, that is a potential pitfall. There could still be loss of the protein. As with most of these pitfalls that I'll mention, the first step is generally to repeat the stain. Do the stain again, see what's going on, see if you get the same result or a different result. If that doesn't elucidate the solution, then you can try one of the other testing modalities that are available. Other potential pitfalls include heterogeneous staining. Some cancers, for whatever reason, let's say half of the cells will be intact staining and the other half will show loss of staining. That's generally interpreted as normal retained staining. But the sort of thing that comes into play there is that there's really no gold standard for how much retention is adequate to say that this is intact. I've seen anywhere, different societies, different authors, different experts will say anything from 10% retention is enough to even one convincing nucleus still showing staining is enough for retention. So there's no gold standard there. So that's another situation where you might want to repeat the stain. There are also situations where the staining, rather than being a nice homogeneous stain throughout the nucleus, will be speckled. I've seen cases where there is aberrant cytoplasmic staining, which usually indicates an aberrancy. I've also seen situations where a rectal cancer was biopsied at an outside institution. The stains weren't performed, and we can't access the block. It's at a different institution. For whatever reason, we can't do the stain. Then the patient undergoes neoadjuvant therapy. We get the resection. There's still cancer there. We do the staining, and MSH6 appears deficient, but this is actually a known complication, potential complication of the neoadjuvant therapy. So we can't look at that and say, well, found it's definitely deficient. It could be, but it's also just as likely to be a side effect of the chemo regimen. So that's another situation where you may have to resort to other testing, whether you want to do microsatellite instability testing, things like that. But this is a brief overview of various rare but actual scenarios a pathologist may encounter, and they just need to have their guard up and be willing to say something smells a little off here. As much as I'd love to just sign this case on and go about my day, I should probably show this to someone. I should probably repeat the stain. I should probably, Google that article I read last year just to make sure I'm not making a mistake. Because it's not just a matter of lynch or not. This is going to throw off the patient's prognosis, how the oncologist is going to approach the patient. There's a lot to unpack in those 4 immunostains.
So you mentioned microsatellite instability testing. What is the difference between these two tests? Are they interchangeable?
They tell you some similar information, but they are not exactly the same. And this is actually, I'll admit, it's one of the things that I sort of struggled with a bit conceptually when I was first learning about all of this stuff. So the genesis of the kind of tumor aberrancy is the mismatch repair deficiency. We have these 4 genes, MLH1, MSH2. I can keep listing them, but they're the same 4. And they encode for similarly named proteins. And what these proteins do is that they correct errors in DNA replication. Let's say you have a nucleotide repeat, AT, 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 AT. It's AT 4 times. Every now and then, in the billions and billions and billions of times DNA replicates, every now and then it's going to accidentally hiccup and spit out 5 ATs instead of 4. Now, if someone has intact mismatch repair, those proteins will say, this sounds like a job for me, swoop in, fix it, and then you're back to the normal 4. However, if it's deficient because the proteins aren't functioning properly, the gene is messed up, the promoter is hypermethylated and it's not encoding the gene, the gene is not being managed properly and the protein is not being created, that 5 ATs is going to persist. And the next time it might be 6. And it might be 8. And it might be 20. So on and so on. And these are the microsatellites. These are the repetitive sequences of DNA that have gotten out of control. So since the problem has to do with a general DNA error repair, the errors can now pop up anywhere in the patient's genome. It's not just like 1 or 2 genes that are affected. It's not like typical colon cancer where you've got the heavy hitters, APC, KRAS, TP53. They're going to have dozens, hundreds of genes accumulating these microsatellites and not functioning properly. So that is a situation known as microsatellite instability. The genome has become unstable because of these proliferating microsatellites because the mismatch repair is deficient and not able to fix these errors. So the testing is not exactly interchangeable. Most labs these days do the mismatch repair protein testing with the immunostains, which tells me, let's assume that there's an aberrant result, tells me this cancer has an aberrant result, and it's these proteins that are not functioning properly. It doesn't actually prove to me that there's microsatellite instability, but if already a colon cancer, I can pretty much assume that it's gotten out of control. I can infer that this mismatch repair deficient cancer is microsatellite unstable. Another method of testing these cancers that some labs use, I've never been at a place that does this as the first line of testing, and I have to admit I don't have much experience testing it, interpreting the testing myself, though I've heard from several people that once you get the hang of it, it's easier to interpret than the proteins, the immunostains. You can simply test microsatellite loci, known loci that you look at the patient's colon cancer tissue and the patient's normal colon. You have to have both samples to compare. So you can say, oh, that microsatellite focus is completely out of whack in the colon cancer. So that tells me that microsatellite instability is on board. What it does not tell me is that, oh, it's because PMS2 isn't working, or it's because MLH1 isn't functioning. It doesn't tell me which protein I have to worry about. And as a result, it doesn't give me good information on, oh, this patient probably has Lynch syndrome, or, oh, there's a good chance it's sporadic. It doesn't tell me that. Really, it just tells me that the patient's cancer is microsatellite unstable, which does at least tell you, oh, don't use a 5FU, use PD-L1, the prognosis is better. So you have some of the information you need, but not all of it necessarily.
And can the mismatch repair deficiency status change through the course of a patient's disease, for example, between early or late stage, or in like metastatic and primary tumor?
Sure. So that is rare, but it can happen. These sorts of mutations are usually what gets the ball rolling in these cancers. So once the cancer is on that course, that's pretty much how it's going to play out. However, there are studies out there looking, they'll look at hundreds of colon cancers and they'll test both the primary and a distant metastatic focus. And they've reported that a small percentage, sometimes up to 5%, but it's usually less than 1%, which sounds more accurate to me, will change. It'll go from being proficient in the primary to deficient in the metastasis, or vice versa. And maybe it's a subclone issue. Maybe, there's something else going on. Maybe one of the two test results are false positives or false negatives. But for whatever reason, there is a small sliver of these cancers where that can change, which is why it is recommended to test the metastatic foci just to confirm, this patient, had stage 2 disease. Now they have stage 4 disease, and it was mismatch repair deficient. But let's make sure that the metastasis, which is what we're really worried about now, is acting the way we think it will, so that we test it properly. And again, there's not a lot of literature on this, but there are some studies out there. And I think what's interesting is that the highest discrepancy is usually in peritoneal or ovarian metastases. Metastases to other organs like liver, lung tend to be the same from primary to metastasis, but it seems to be, a higher rate in ovary or peritoneum. If you test, you'll find a discrepancy there.
Okay, so moving on to some of the more emerging biomarkers in metastatic colorectal cancer. I know you mentioned HER2 earlier, but are there patients right now that you would feel could benefit from either HER2 or NTRK testing?
Sure. So let's talk about HER2 first. HER2 obviously is extremely important in taking care of patients who have breast cancer and upper gastrointestinal tract cancer, gastroesophageal junction, stomach. It's not as crucial in colon cancer. Maybe some people would disagree with my statement, but the reason I say that is it's a small percentage of colon cancers that have HER2 abnormalities. Less than 5%, probably less than 3%. It's not something that we're testing first line in our colon cancers here the way we are in our upper GI tract cancers. We will test it on clinician request. In fact, I interpreted an immunostain this morning on a colon cancer for HER2. But the cancers in the colon that tend to have HER2 abnormalities are RAS and RAF wild type, and they're usually microsatellite stable as well. So if you've got a cancer where you've done all the other testing and nothing's popped up, KRAS, NRAS, BRAF, microsatellite instability, nothing gave you something to grab onto, that might be an indication to do the HER2 testing. And I will point out that the scoring metric for how you interpret the immunostain in the colon is different than it is for breast and than it is for upper GI tract. It's publicly available. You can Google it. It'll pop up. There's also, the original paper, I think, was in Modern Pathology. But it's not just a matter of looking at it and being like, oh, that looks 2+, I'll do FISH. It's a combination of what part of the cancer is staining and how strongly and what percentage. You can have a cancer that's staining pretty strongly, but based on the percentage, it might not be enough to be considered equivocal or positive, and you would simply call it negative. Now, it is still the same in terms of a positive immunostain is considered positive, and therefore the oncologist can proceed with anti-HER2 therapy. If it's negative, they can say that's off the table. And if it's equivocal, you can do FISH testing on the equivocal colon cancers to get your final definitive result. But again, it's not the same method of interpretation exactly as for upper GI or breast. You also asked about NTRK, which is sort of one of these fun little zebras that we concern ourselves with. NTRK abnormalities are extremely rare. It's fewer than 1% of cancers overall, and that includes colon cancer. Most of the time I see it like 0.3% or 0.5%. It's very rare. These cancers tend to also be RAS and RAF wild type. However, they are usually mismatch repair deficient. So that's the scenario where you would look at a cancer and say, okay, it's mismatch repair deficient. So I'm already in that ballpark. It's RAF and RAF wild type. And we didn't talk too much about this. We can go back to it if you want. But if it's BRAF wild type, the patient likely has Lynch syndrome. It's likely not sporadic. But that's sort of the situation where NTRK testing is indicated. There are a couple pathologists I've worked with who are like, the NTRK gurus, but it's not something a lot of people, in my experience, are dealing with yet, just because it is still an emerging test and it's so rare. I will admit I've never knowingly seen an NTRK mutated colon cancer. I've seen enough colon cancers that at this point, one or two of them had to be, but we're just not testing them. So, I couldn't speak to that.
So we'll see if you can answer all of this next question, but I want to look at the different advantages and disadvantages of testing via immunohistochemistry versus other molecular methodologies. So for HER2, as well as NTRK.
So for HER2, it would be immunohistochemistry and FISH. The third option would be molecular testing, but you probably wouldn't do molecular testing on a cancer just to look for HER2. You would probably do it as part of a comprehensive next generation sequencing panel. You do one of these 200, 400 gene, whatever tests that gives you a lot of information, and HER2 will likely be included in that. So for HER2 testing, there are a couple different modalities, and I think it's Ventana and Hercept test. I may have to double check that, but there are a couple different immunostain platforms that can be done. And they're largely comparable. They're not exactly the same. And if I recall correctly, I think the Ventana does a little bit better, but it's not something I'm knowledgeable about. And I don't want anyone to hear that and say, oh, then I'm definitely using that platform and not the other one, because it's really a situation where if you're going to bring the test online, you should see which one works better for you and which one just functions better in your lab, because so much of this is just local lab conditions. So once you know which stain works better, you just need to get good at interpreting it. And again, I'll be honest, we see these infrequently enough that every time I still pull up the table and I say, okay, let me make sure I'm interpreting this properly, because it's not like we're getting 5 of these a day. We're not even getting 1 a week at this point. It's infrequent enough in the colon. But once you have a colon cancer where you're saying the HER2 is equivocal, then you're just going to go to FISH. That's what you're going to do. So that is the standard of care for those. It's not a matter of is HER2 better or is FISH better. If you wanted, you could in theory do FISH for all of them. Maybe, I know some research labs as part of their work will do HER2 and FISH on all of them. But most places, I think, as with other organs, are doing the immunostain first and then going to the quote gold standard for FISH testing if necessary. Now, NTRK, I will admit I have no experience with. These are so rare. I think it's just a matter of preference. It might even be, most people listen to this podcast, I would assume also don't have the testing in-house. If they do, then I'm very jealous of you. But I don't think many places have this on board yet. So it might not even be a matter of which test do I think is better. It's which one am I able to order? Which one can I get sent out to a laboratory? That said, I do think that the immunostain and the kind of molecular fusion testing are fairly comparable. I think they tend to tell you similar information. I don't think there's a wide discrepancy in the results that you get from that testing. So whichever one your laboratory brings in-house or is the best solution for you to send out, that'll probably give you actionable results that you can feel comfortable utilizing.
So are there any other emerging biomarkers that may become standard in the coming years? Do you think HER2 will become more standard? Is there anything else kind of on the horizon?
Well, there's always going to be emerging biomarkers, and there's always people pushing for a new standard. I think the past couple of years, HER2 has, I shouldn't say to my surprise, but I'll say to my surprise, become fairly well adopted. I say surprise because it's such a small sliver of colon cancers. It's not nearly as common as it is in breast and upper GI. But of course, I understand that oncologists want to give patients the best chance to do well with their disease. And of course, if something, if the number needed to treat is 20, 30, 40, sure, do the test. If it's NTRK might be a little different because if you're dealing with 1/3%, then what's that 300 number needed to treat? I shouldn't be doing arithmetic on the fly, but at some point you start to have to considering the sort of the economic scenarios that you're dealing with. Unfortunately, I'm not, no one's happy about that fact, but it's true. But I do think HER2 is becoming standardized. And if you look at the latest colon cancer guidelines published by the National Comprehensive Cancer Network, they do recommend HER2 testing on the RAS/RAF wild-type colon cancers. They talk about NTRK testing, but it's really sort of tucked in there as, this is something you could do, and it's usually the RAS/RAF wild-type mismatch repair deficient, but it's not truly part of their sort of workflow algorithm yet. Again, give it a couple years, maybe something new will come up with NTRK testing, and you can have me on the podcast again just to say, I was wrong, I'm sorry.
And then you can tell me everything about it because you guys will be doing it.
Or we will be. Now, other biomarkers coming up. PD-L1, of course, is hot in pretty much every organ. It is not standardized in colon cancer yet. Other GI tract organs have seen a lot more activity with PD-L1. There are studies looking at it in colon cancer. And to me, it doesn't feel standardized yet in colon cancer, but I'm willing to predict that one, give it, I want to say 3 years, so it's probably going to be like 6 months in actuality. By the time this podcast is released, we'll be doing PD-L1 on all colon cancers. I think that one will happen. And it's just because the therapy is so effective for so many patients, and it's a large enough percentage of these cancers that benefit that I think, and you can do it for so many other cancers as well, that it makes sense to bring it into your lab if you're getting those requests often enough from your clinical team. So I think PD-L1 will become standard. Other things people are looking at, we did talk about, kind of genome-wide sequencing of these cancers. One thing that people are looking at more and more, though I will admit this is another thing I don't have personal experience with, is tumor mutational burden. How mutated is this cancer overall? How does that play into prognosis? How does that play into therapy? I did mention that mismatch repair deficient colon cancers tend to have high mutational burden because mismatch microsatellites are going to pop up throughout the cancer genome. So you're going to have hundreds of genes mutated. So those are kind of hypermutated. And there's actually a small sliver, maybe 1 to 3 colon cancers that are ultra mutated because they have polymerase proofing deficiencies, something like that. The genes are Pol E and Pol D1. And it's a similar situation where mistakes in DNA replication cannot be repaired properly. And then just, everything goes haywire. So that's another situation where you would see a very high tumor mutational burden, and the oncologist may need to take that into account when designing their therapeutic regimen. There are some other specific genes. Every now and then I hear a bit about PI3KCA, but I'm not aware of a lot going on there. I'm sure if you look at the basic science literature, people are finding genes all the time in mouse models, rat models. I'm sure there are some phase 1 clinical trials on various things that are coming up, but I don't think any of them are hot enough that in the next 6 to 12 months, they're going to be standard. Maybe 6 to 12 months, we'll be hearing about them, and then another year or two, we'll be able to offer wonderful new therapies to colon cancer patients. But I'm comfortable saying that's pretty much where we are at the moment.
Well, I think that concludes all the questions I have, and I want to thank you again, Dr. Gonzalez, for sharing your insights on the podcast today. And goodbye and take care.
Thank you so much.